This conference will now be recorded.
So good evening, everybody. This is before a regular session of our early low intermediate risk active surveillance prostate cancer group. And the reason we're having an education session right now is because we have an honored guest, Dr. Michael Liss from UCSD San Diego, who is going to talk to us a little bit about gut microbiome. And I believe is also looking for a few 3+3 peeps to fill up a trial, although he does promise me, and he will tell you, that we will be having a trial for you more advanced guys coming down the pike. I don't want to take a lot of his time because we've only got half an hour, so I'm going to pass it right to you. Oh, and I should say we should thank all the people that allow us to do this: Bayer, Janssen, Myriad, Johnson & Johnson, Novartis, and Foundation Medicine, and I think somebody else who I forgot. So, Telix. There you go. All right, over to you, Dr. Liss.
Great. Well, thank you very much for having me. I am a urologic oncologist and surgeon, so I take care of a lot of prostate cancer in my practice. I do have multiple hats, so I have the UCSD hat, but I also have a startup company based on a lot of the science I'll talk about today. We had patented when I was in San Antonio, and then I had moved just recently to UCSD to be part of the big microbiome center here. So I'll go to, hopefully this is in presenter mode. And so this is the company, but this is my title. And so my disclosures are that I'm a founder of this Oncobiomics company, and I just leave the QR code up there because we'll be talking about one of the trials which led to this particular talk. And so this is the contents. I'll talk a little bit about microbiome, prostate cancer, algorithm development, what we were finding and what led to this trial that we're doing, and some modifiability, and then any other extra questions that we have. So this is the old school way of how we used to do microbial research, right? These are agar plates, and this is on a wall at a Amsterdam museum called Microbiome. And of course, someone who's interested in microbiome takes time out of their day to go to a microbiome museum in Amsterdam. So, but this is, since the 1800s, this is how we found out about bacteria. And when I started in microbes, I was researching biopsy infection, and many of you have researched that before your biopsies as well. And then over time, some of that study I was doing led me to, I can marry microbes and cancer at the same time, and that's what led to a lot of my research. And so this was another one of those virtual tours, as we're in a virtual room, that you can see these 3D images of where bacteria live in our body. And you can see the colon is basically loaded with microbes. And we know that there's actually more microbes on our body than human cells. And so what does that mean is that they're making metabolites, they're interacting with our immune system. It's a huge part of our being, and a lot of times we don't really give it the attention that it should have. And so I usually show this picture, not that I'm a Florida Gator fan or anything, but this bird will not be eaten by the crocodile. What it's doing is cleaning its teeth. And so when we think about bacteria, a lot of times we go to, it's pathogenic, it's harmful, but we forget all the good bacteria that make vitamins for us, that help digest our food, that train our immune system. So this is really a symbiotic relationship, not necessarily a pathogenic one. And so what is biome when we talk about microbiome? Or micro is microbes. Biome is, here we go, 4th grade. We're learning about the different areas of, even the United States. The bacteria or plant diversity or animal diversity that's in a prairie grassland is not going to be the same as the coastal scrubs. And so, or the desert, right? So your skin may be more like a desert, and the prairie grassland may be more like the mouth. Deciduous forest may be more like the colon, right? So when we compared the bacteria from different locations, they look very different, but it's even harder within that area. But we also know that taking the wolf out of one of these biomes is going to change everything, downstream, upstream, right? So small changes in the biome have interacting effects with the world around us. And so I like to talk a little bit about a microbiome primer, just so you know how do we even study this stuff. And so there's kind of diversity factors that we take into account, and alpha diversity meaning how many different kind of microbes are there. So when you see that, it's just telling us from, a count 1 to 20, are there 40 different kinds, are there thousands? Then beta diversity is how two groups are similar or different to each other. So when we do research, let's say cancer versus no cancer, we're going to compare them by beta diversity, saying this group of bacteria are more or less like something else. And so when we line these all up, so sample A and B, C and D are maybe different patients, okay? If you line them up in a little table, we can say, okay, sample A has 3 greens, 2 purples, and 2 whatever color that is, brown. And then as we go down the line, we can basically plot these on 3 dimensions, and we can see that D and A are more closely related, and B and C are really far apart. And so that's how we start to decide which combinations of bacteria are associated with certain diseases. And so, when I was doing my research on biopsy infections, looking at E. coli, this paper came out from the Human Microbiome Project. And this is exactly, this graph is what I just taught you guys. So the GI tract is at the very top of this graph. And then the oral microbes are the orange, off to the side. So those are all very different. Skin and nasal are interspersed because it's kind of part of that. And so this is just in general the biomes, but when you dive into one of these, let's say urogenital, then you have to divide out by different disease types. And so when we talk about the microbiome in prostate, we need to be specific that are we talking about the diet and the gut microbiome, or are we talking about the microbiome that's within the prostate? And they're very different. And so within the prostate, it's a little different. We can get it from urinary samples or tissue biopsies. We can see what types of bacteria are in there. But it's a different question about what I'm talking about today. So today we're going to focus a little bit more on the gut microbiome. And you can see at the top, we start with diet. It's a very huge influencer on our gut microbiome. And then as we go down, we can look at what type of inflammatory factors do those bacteria produce? Does it influence the immune system at all? Is it involved in fatty acid or bile acid metabolism? And all those things impact how we metabolize food. Are we absorbing micronutrients? Things like that. And so prostate cancer, as we know, affects 1 in 8 men. And we had this finding that Crohn's disease or ulcerative colitis may have had an impact. There's a couple of papers out there that came that showed that there may be this influence of inflammation in prostate cancer, which kind of led us on this journey. And so inflammatory bowel disease is a risk factor for prostate cancer. So a lot of people are like, well, how can something in the gut affect the prostate? And they're not really connected. Well, there's a couple different ways that they can impact each other. One is that bacteria in the colon can go from the colon and put stuff into our bloodstream, metabolites, inflammatory factors, things like that. There's a lot of lymph nodes around our colon that monitor the microbes that are in there. And there's this training effect where our immune system can be affected or trained by certain exposures to different bacteria. So that can happen. And then the other part is that there can be transfer from rectum to prostate via the urethra. A lot of men can have urinary tract infections or some other reason to have them, or they're just colonized there. Once we're colonized with the bacteria, it doesn't mean you have an infection, like I said before. So there is interactions between colon bacteria and the prostate. And so this was our first publication several years back when we first started saying, are there biosynthesis or there pathways that bacteria are producing that would link microbes to cancer, essentially? And so we can't say that it causes cancer. We're just saying that there's a type of milieu, there's a type of community of bacteria that tend to occur more in those who are diagnosed with cancer than those who are not. So this was the first hint that there may be something there. And so on the right side, we are looking at folate and biotin. And if your microbes are making those nutrients for you, you did better. Whereas and the starch and the sucrose, meaning a lot of the sugars and the carbohydrates, if you have a lot of bacteria that like that stuff, well, then you're probably eating a lot of that stuff and it may not be helpful for you. So just the people who are diagnosed with cancer tended to have more of those bacteria that focused on starch and sucrose and carbohydrates, whereas those who didn't have cancer had more B vitamin biosynthesis pathways. And so since then, a lot of more papers have come out showing the same thing that I just talked about before, that maybe the diet can modulate these bacterias and lifestyle. And then on the right side here is all the different types of interactions with immune cells that has been shown, and even genotoxins. So some bacteria can produce a toxin. We know this in colon cancer. It's called colibactin. It can damage DNA. Can this happen in prostate? And so this is what our lab is kind of focusing on. How does it interact with cells? Can it damage DNA? How does it influence the immune system? Things like that. So this is how we kind of developed an algorithm and kind of got a list of different bacterias. And I'll kind of go to our results. So this is from about 800 men before they had biopsies, and we can see on the left side the deciles, meaning that for each score from 0 to 1, from each kind of, if you divide it by 10, the higher the score, the more likely that we're finding prostate cancer. And then these scores on the left side are kind of what is your AUC curve. So this area under the curve kind of tells us the sensitivity and specificity of the test. And PSA is probably around 0.6, 0.62, something like that. And so we had a good cross validation that, okay, we're finding cancers, and then the purple was clinically significant prostate cancers. And then we compared this to the PCPT risk calculator, saying that, okay, we're not far off of, if you went into a risk calculator, put in your PSA and your age, what would your risk be? The microbiome was doing, seemed to be doing as well as some of the risk calculators. And so the interesting part is that we did do pre and post testing. So this was on the upper graph here. This was your baseline. So the people in red had a really high microbiome score, and then we retested them, almost 500 days, about a year and a half later. And those people that were high before remained high. Those people in the gray that were low before remained low, and everyone in the middle can kind of bounce back and forth. And on the bottom shows the longitudinal risk. And so what this shows is that from baseline, we took everybody out that got diagnosed with cancer, and then we followed them for up to 8 years in some people, but mostly around 4 years is when we got most of the follow-up. And we showed that if you're high on this microbiome score, that the likelihood of clinically significant prostate cancer, that would be D here, was much higher, over time. And so that's what we got excited about, in that, okay, maybe there is a link between diet or microbiome and a future diagnosis of clinically significant prostate cancer. So I did want to talk about, okay, if the microbiome is causing all these things, there's a lot of excitement about fecal microbiota transplants, meaning, can you take someone else's microbiome and put it in yourself or for treatment? And so it is really exciting. It can boost some immune issues, and there's some great stuff coming out about it. But the issues are that the regulatory environment, if you remember, with blood transfusion, let's say, right? We didn't screen very well for that. And in the beginning, there was a lot of issues with infection, matching, things like that. And we don't fully quite understand the long-term side effects of FMT. So that's what's going on right now. There's a pretty strong regulatory body monitoring if this is something to do, and I don't really recommend doing this at home or anything like that. There's a couple documentaries and series out there that kind of show to be able to do this, but I don't recommend doing that unless it's in a clinical trial. And so this is what we're trying to get through. Can prostate cancer microbiome be, therapeutic? Can we, in the very top here, can we find a favorable category and an unfavorable category? Can we use FMT or something similar in the future? I think that the very bottom, called bacterial consortium, is probably the way to go, that we will find these favorable and unfavorable, and we can start to manipulate the microbiome. But for now, what do we have? Diet, prebiotics, probiotics, postbiotics, meaning just giving you what the bacteria would make. Now, we don't understand each one of these implications, and this is what the impetus of our study is, to start looking at just the laboratory protocol, making sure that we have it the same way every time and we're getting very consistent results. We'll then work with the FDA to say, okay, yeah, this is a test that is saying what it's supposed to be doing, and going through all the processes from our algorithm. And this is kind of a mock report of what we're aiming for. So you would get kind of what your score is. My gut bacteria are more similar to those who have higher risk or lower risk. We would have the certain bacteria, and then what action items would you be able to do, which would include diet, probiotics, supplements, or other. So this is just kind of a mock report that I put together to show you what we're trying to get to. But first, the first thing we need to do is validate our SOP, and we want to get men in active surveillance. I know it's 3+3, but right now all of our algorithms we're testing for clinically significant prostate cancer, which we defined over 10 years ago as 3+4. So that's why I can only include 3+3 men for progression for now. We will be rolling out a separate study for more advanced cancers, especially if you're getting treatment, because we know that each of those treatments affect our gut differently: chemotherapy, immunotherapy, surgery even. So we're working on a secondary test that's going to be available here in the next few months. And you can keep up on that by just emailing us at the company. And so that was my presentation. I can answer a few questions. There's 10 minutes left.
So how do the gents sign up if they would like to, and talk about the trial a little bit?
Sure. So the
Do a
trial,
little self-promotion, please.
yeah, I'm always hesitant about it just because I want to make sure I'm not overstepping my bounds. So I'll go back to the QR code. So if you go to this, just leads to the website. Even on the website, there is says here, sign up for the study. You can go in and just put your email in. You put your email in, you'll get sent an email. You have to make sure it's from Castor. That's the company we're using as the electronic database and e-consent system, because we want to make sure it's all secure and approved. So then once you put your email in, you'll get an email from Castor. Check your junk email too. Sometimes it happens. Go in there, you fill out a questionnaire. It's 5-6 questions, and then that will determine your eligibility. So if you get kicked out after that, if you've had antibiotics, or if you have prostate cancer grade group 3 or high, or grade group 2 or higher, I can't put that in this particular trial. Like I said, we're expanding in the future. And then from there, you'll get if you qualify, you'll get a Calendly invite to sign up. You'll get the consent form that you can read through, and you'll sign up for a time to do your e-consent. We like to do it live. A lot of companies will just put a checkbox, but we want to have that interaction with you to tell you, here's the kit, here's what you're going to get. This is how it's done, to show you everything that you're going to get. You'll get a sample in the mail. You do a stool collection kit. This particular kit is FDA cleared, so that's why we have to do it this certain way, because we're trying to get work with approval bodies to make sure that the test is accurate and complete, all those things. So we do it the way that they have approved, which is, it is a scoop. It's small though. It's pretty easy. Done it myself too. I have a family history of prostate cancer as well. And so once you send that back to the lab, Typically, it may take 4 weeks or so right now because we have to do them in batches. So I ask that people be patient with us as we go through our processes because we have to batch them as we do the sequencing. But you will get a report back on that alpha and beta diversity and kind of what your general microbiome would look like. You also get a healthy eating index, which actually was just published, I think, in JAM Oncology, showing that if you had a poor healthy eating index, that your progression rate was higher in active surveillance. So you'll
Yeah.
get that as part of the study, which is nice. And $25 for your participation if we get all that information back.
Right. And we only take 10% of the $25 here at ANCAN as a donation. Now, before I'm going to take the questions, but this is a group who likes the chat window, probably more than the QRL or whatever you call it. So,
Okay.
what is your URL? And I'll put it in the chat window for everybody.
Well, here, can I have access to the chat?
Oh yes, you do. Of course. Just stick it. Just stick your URL in the chat window, and since you can, I know you can multitask. I'm going to go. We got 4 questions. I'm going to go to the first question, and whilst you can listen whilst you're putting it in. So the first question, I think, comes from Derek. He had his hand up first. Derek.
Hello, Michael. Thank you for joining
Hi.
us. Very
Thanks.
good information. So you mentioned 3+3 gentlemen so far for the study and nothing greater. What about less than 3+3? Are you reviewing them?
Yes. So anyone who basically has a PSA and has a prostate can join it because we're comparing it to your future risks. So about 150 men we're going to try and do would be either high risk or elevated PSA, undergoing a biopsy but haven't been diagnosed yet. And then the other half, I'm trying to include the active surveillance population, at least 3+3 in this initial one, because a lot of that wasn't represented in our first algorithm. So I want to make sure that this algorithm works for those men to start, and then we can build off that. But yeah, if you have
Thank you very much.
thanks. Yes.
Okay, so I didn't see it in yet, but is HT is this correct, Dr. Michael? Oncobiomics.com?
Yep, there it is. I found your chat
Okay,
button.
so if you go there and scroll down, I think you'll find you have to scroll down to find the research study.
Here, I'll put the actual link in there.
Okay. Next person up is Dr. John.
Thank you for your talk. Could you tell us about eating fermented foods versus taking probiotic capsules?
Yes. So good question. It's a common one. So for probiotics, I'll start with that. It's challenging because a lot of probiotic companies do not test if they're actually getting to the place that you want it to get to. And so a lot of times you take a probiotic and it gets destroyed in the stomach. So you need a time release or a double capsule to get through the stomach. Or if you're taking a PPI, a proton pump inhibitor, because you have GERD or reflux, that actually helps the bacteria go down. Then when it gets to the colon, it only stay there for maximum 24 hours unless you take it over and over and over again. So some companies have been able to do that, and I think that occasionally it will change the flora, but you really have to be consistent on it. As far as the diet goes, I think there's a lot more. The concept is different, and now you're feeding the different bacteria rather than just providing the bacteria. The problem is just planting the wolf in the desert. He ain't gonna live, right? So maybe you need to make the desert a rainforest, or a forest, so you can put the wolf in there and then it survives, right? So the mixing between the prebiotic and the fermented foods can help maybe the probiotics work. So I think there's going to be a combination effect of these things.
Okay, Dr. John. Or did you want to know whether you should be eating dill pickles or kimchi?
Yuck.
The kimchi is better, unfortunately, but for taste wise for some people, but the dill pickle just has too much salt in it.
Yeah.
But an occasional beer is okay. That's fermented as well.
Okay, we like this, Doc. Any of you in San Diego? We got a doc. We have a doc for you. Um, let's see who's up next. Dr. Mark, did you have a question for? You always have a question, Dr. Mark.
Thank you. Thank you. Enjoyed the talk. And it's my understanding that when we show up with metastasis,
There we are.
those cells
Yeah,
were
but it thinks when I'm
seeded
going to have to
at the
unmute.
time of the initial diagnosis, and they lay dormant until they're acted upon at some point later on. And it may be the gut microbiome that is turning on these dormant cells, causing them to activate. Have you looked into that line of research?
Yeah, so I think what the it's a little hard to prove. We'll just put it that way, right? So what people are doing is choosing the indirect pathway of like micronutrients, um, inflammatory pathways that could be activated, so things like that. So it's hard to say that this microbiome is going to do that, but that's where I'm trying to bring these clinical trials. And can I first find a bacterial milieu that's predictive of somebody that's going to progress? Then I can take those men and randomize them to some type of intervention to understand that a little bit better. And I know everyone just wants it now. I get it. I wish I could tell you. And I said in one of our last meetings that one of the easy things that you can do is try to increase the diversity of your diet. That's something you can do today. And basically, what we said last time, and everyone was joking at the very beginning of the call, I said 25 different vegetables a week. So you make a list, put it on your fridge. Like, when's the last time you've had eggplant? When's the last time you had a celery? A lot of times we have carrot and corn and stuff like that. But don't think of the rarer types, but just list green beans, like the whole thing, right? And then if that's the case, you're going to get most of the nutrients. You don't need to take vitamins. You're going to get the prebiotics. You're going to get all the benefits. I wouldn't worry about serving sizes. You know, um, just try to diversify the plants, not fruits, but plants. And so when you say plant-based diet, I think this is what people are talking about. And I don't want to say diet because diets are hard to follow. If you just increase the vegetables, it's going to make you fuller, and you'll feel like you're eating healthier. And I do believe that. And then exercise is definitely important too. So I know it didn't fully answer your question, but we're working on it. But it's hard to make leaps that the microbes will definitely control small areas of metastasis. But I do think in the long run, there's something we can do about it.
So I want to say that Dr. Michael obviously likes 3+3 guys, because when he presented to us last time, he told us we had to eat 30 vegetables a week, and now he's cut it down to 25 vegetables a week. So he's obviously a little more he's encouraging you more. I got up to, here's my sheet, and you probably can't see it. Here's my sheet. I wrote everything down, and I think I got up to 22. But
Maybe you skewed me. So there is a documentary called Hack Your Health on Netflix. It's from our UCSD crew here, and I think they said 30, but we always talk about between 25 and 30. We have the overachievers that can do it. I said it's hard for me to do it, but I said it's the journey and not necessarily the achievement. So as long as you're doing something, I think you're going to be better off.
okay. And what did you say? Hack your health. I'm putting that in the chat
Yeah,
window.
I'll put it in there.
Okay, you put it in. And Michael from Tennessee, Michael, we got something. You got a question for us?
Yeah, just real quick. I'm sorry. Super nice to meet you. I just actually had my PRIMUS study order submitted, but you mentioned the diet and you mentioned the gut biome side of things. As part of this study, is the oral aspect covered at all? I asked because I did an oral DNA lab test not too long ago and was able to fix a lot of stuff just with like mouthwash and a lot of kefir and that kind of stuff. But
Yeah.
But I was just curious if that's Is all of that part of this study?
Eventually, so as part of the study, what the purpose of the study is to confirm the standard operating procedure at the lab. Once you bring a test out of a academic laboratory into a kind of production environment, you have to make things change. So you have to make sure that it's saying exactly what I said before. So that's the main goal of the study. But knowing that no one's going to send their poop in for nothing, we have to give you something, right? So I got to give you a little bit of the microbiome, and I added the healthy eating index score in there to kind of help with that. But in the end, I showed you that report, that mock report, is we'd be giving diet, probiotic, prebiotic type of recommendations. And then my hope is you pick one or two of those, change something, and then redo the test to see, okay, did it work? And then I want to know, did it work, right? And then it builds the system like, okay, these are working and these are not working. So the next version will be better. And then we follow people for up to 5 years to say, okay, yeah, is this showing longitudinally? Is it working? So that's what it's about. And yeah, we're hoping to get to that kind of oral type situation.
Okay, and the very last question, because that will allow people to come in as we gather, so we won't have to wait for people to gather, comes from our brand new moderator, Eric.
Thank you. Thank you, Dr. Michael. I just finished the surveys and I'm ready to go for you. I'm waiting for my kit to arrive in the mail.
Oh, thank you. Appreciate
that. Thank you. Quick question is, do we have to do anything special as far as anything to do before the stool sample, like eat fast or eat a certain thing, or?
No, I prefer it to be kind of your regular state of health, right? So not after Taco Tuesday, preferably if you have diarrhea or something, don't do it then, right? It's just kind of like, well, Saturday morning, I know at 7:30 I'm gonna have a normal bowel. Like most people can do that. If you're not that kind of guy and you're like, well, it's pretty sporadic, just try to do it at home when you're comfortable and you're not around anybody, so you can concentrate on the instructions. If you got, kids or guests in the house, like kind of wanting to get in the bathroom, you get frustrated and you're kind of, so just that's usually what I try to tell people is go through the instructions first. If you have any questions, my coordinator can answer some of those for you if you're just like, oh, I don't quite understand. But I think taking it all out, looking at it, right, before you go in, so okay, this is what I'm supposed to do. It's really just a spatula on the top, put the cap on, send it out. Should be very self-explanatory, but it'll be very helpful going forward. The one thing that everyone asks me at the end of my clinic visit is, what dietary recommendations do you have? What should I eat? What should I not eat? And we don't know what to say. We try to go with healthy diet and exercise. Okay, it's just generic. I'm trying to get to, in the specific person, what is the exact recommendations that I should be giving you as an individual, not just the generic stuff. Because I think then you can have a number like PSA. We can follow that number over time. I know what you're doing. I just think this type of thing would be very helpful clinically.
Thank you.
So I will say one thing for you, Dr. Michael, because you might find Eric a very interesting subject. Eric has 11 out of 12 positive cores, and they're all 3+3. And we don't see that. I don't know how often you see that sort of that often, but it's
yeah. I just have a 40, person in their 40s come up with 9 out of 12, and I see that, and it's really hard. You're like, okay, I got to follow you just so close, but I don't want to react to that yet because
right.
There's and I'm part of that core that says this doesn't move on us. Surely we're worried about it, but is there a way? And so something like this is for Eric, and for these guys that can, okay, you want to take control, right? You lose control. You're like, I can't, okay, you just told me we're just checking PSA. I'm doing nothing here. How do we get past that and give some power back to the patient, right?
This is music to a couple of our ears. Now, Look here, Dr. Michael, we don't want to throw you out. You are very welcome to stay in and listen to the conversation in the active surveillance group if you would like to, for 5 minutes, for 10 minutes. You can leave right now. We're not throwing anybody out at all, even if you have advanced disease. Please feel free to stay and listen to some of these active surveillance guys, but we are talking active surveillance 3+3, 3+4, hopefully low intermediate. If you're high intermediate, you may be visiting with Dr. Mark. Dr. Mark, wave your hand. Wave your hand. You may be visiting with Dr. Mark in the low intermediate group, and we hope none of you are going to be visiting with Dr. John and I in the high risk recurrent advanced group. That's what we hope. So I want to thank you immensely. This was great. Maybe we'll talk to you again. We may have more questions. Anything we can do to help you promote this study, truly we're happy to do. And I will probably drop you a line on. There's another topic on my mind I want to ask you about. Unrelated, totally unrelated.
Well, I want you guys to be able to freely share, and you can invite me back if there were specific questions. I'm happy to rejoin at a later time.
We will. And if you ever want to reach out to any of the low intermediate or advanced guys or any like that, you'll just let us know and we'll hook you up. Okay.
Thanks, everyone.
Thank you. Thanks a million. Thank you. Where's that clap? Where's that clap? I think there's on the React somewhere. There's a clap. Yes, there's a clap. There we go.
So, Rick, I think you need to turn the recording off.
I am going to return the recording off right now.
Okay.